Hello and welcome to the Imprint Weekly Podcast. I'm John Kelly, senior editor of The Imprint, a daily news site covering child welfare and youth justice around the country. You can read our coverage at imprintnews.org or check us out on Facebook or Twitter at The Imprint News. You can also sign up on our homepage for our free weekly and monthly newsletters. And for professionals in child welfare and youth justice, subscribe to our Youth Services Insider section for a closer look at news on business policy and practice. The Imprint Weekly Podcast is also a member of the Safe Camp Audio Network. You can check out our show page and all of Safe Camp's other great podcasts at safecampaudio.org on the web or at Safe Camp Audio on all social media. So we do not have a new episode today because of the holiday, but I did decide to resurface one that we did quite a few years back because the issue at hand in it is back in the news. And while both are Maryland stories, right, both the podcast episode we did and some new reporting by the Baltimore Sun, I think it is safe to say that this is not a Maryland problem that you're about to hear about. And I do think this is probably going to resonate with listeners in other places. So the story in the Baltimore Sun, which is reported by Jean Marbella, is entitled 144 Maryland foster children were stuck in hospitals, sometimes for months, after doctors cleared them, lawsuit says. So I'm just going to read from the top of this story so you know what I'm talking about here. One foster girl was discharged from the hospital but remained there for months while caseworkers looked for a home or other facility to take her. By the 71st day, staff noted she was, quote, hurting self to feel something, end quote. After 4 months of living in a hospital, one boy started ingesting, quote, non-food objects, end quote. Even a girl finally released from the hospital came to harm. Rather than going as recommended for substance abuse treatment, she ultimately ended up in a hotel under supervision, but got out and obtained fentanyl. She landed back in the emergency room, quote, with open wounds and needing detox, end quote. They're among 144 children in Maryland foster care identified in a new court filing as having overstayed at hospitals over the course of 2 recent years. Now, the story notes, as I just mentioned there, a window of 2 years that this has been happening, which must be the scope of the lawsuit, because back in 2022, which is well over 2 years ago, we had 2 experts on the Imprint Weekly Podcast for an episode entitled Stuck Kids to talk about this exact same thing in Maryland. Those 2 experts were Erin Dorrien, who at the time we had that conversation was vice president of policy for the Maryland Hospital Association. She is now the associate principal at Health Management Associates. And Carrie Etheridge, who was and is still the director of social work at Sheppard Pratt. The story in the Baltimore Sun from this month is really a great explainer piece on the present situation and what's happening with this lawsuit. Marbella does a great job sort of laying out the lawsuit and the conditions on the ground, some really helpful context in it about a legislative work group that is kind of on this right now, trying to come up with some proposed fixes. She's got some great React commentary from people who are a little bit skeptical that what the indications of that work group so far are suggesting will work. Our conversation back in 2022 with Dorrien and Etheridge, we really focused on the why of it all. Why are foster youth getting stuck in hospitals long after such a restrictive setting is necessary, which was a problem that seemed to be very acute at the time in Maryland, obviously still is now. I think in the conversation, you're going to hear us talk about some hopes for legislation that they had back then, which I guess I'm actually hoping didn't happen because it's honestly worse if they pass some sort of legislative fix and this is still all going on. I think it's worth a quick listen here because just first, I just really highly doubt Maryland is the only place this is happening right now, where you have youth who have already entered foster care getting stuck in hospitals or hospital-like settings for very long periods of time. I've read through the Baltimore Sun reporting. I'll drop a link to it in the show notes. It's a very good story. I've read through some of the lawsuit. I can't say I've read through the entire thing yet. Obviously, I had this conversation with 2 experts really on the front lines of this back in 2022. Nothing about the details really screams like unique wrinkle in Maryland to me. It very much feels like a circumstance that could easily be happening anywhere. And if you do know of this after you've listened to this interview again or for the first time, and it kind of resonates for where you are at, send me an email at tips@imprintnews.org. And I just think consider what is happening here. That's why this was worth resurfacing to me. I mean, you have youth who have entered foster care, right? So they've been separated from their families. Many who have experienced abuse or neglect. I'm willing to bet some probably have entered by way of a parental relinquishment situation, just given the circumstances that we're talking about here. And then some crisis necessitates a hospital stay to stabilize them, which now becomes part of their record that makes it harder to find another place for them to stay. So they just stay in the hospital. I mean, other than jail, it's really hard to imagine a worse situation than you're just in this high security setting with very little contact outside, probably no schoolwork going on. And it's a place that nobody thinks you need to be. These kids are not staying in these places because anybody agrees they need to be there. So I think it's an interesting listen. Let me know what you think. Once again, here is our interview with Erin Dorrien and Carrie Etheridge. A seriously traumatic impasse has emerged in Maryland's child welfare system, and it involves some foster youth in the state getting left in hospital rooms long after that is actually medically necessary. It's yet another story of capacity pressures in the system that either directly or indirectly lead to really bad outcomes for kids. To talk about that today, we are joined by Erin Dorrien, Vice President of Policy for the Maryland Hospital Association, and Carrie Etheridge, Director of Social Work at Sheppard Pratt, which provides mental health services, substance abuse treatment, all kinds of other supports in the state. So guys, thanks for joining us on the Imprint Weekly Podcast.
Thanks, John. Happy to be here.
Thanks so much, John. I appreciate it.
So before we get into this quite weighty situation, let's let the listeners get to know you a little bit. I'm going to ask for each of you to give me at least one favorite, your favorite TV show or movie, book, sports team, or musical group. I'm going to choose Carrie to go first. Carrie, what do you got?
Well, John, since you on Zoom could see the back of my office, I'm going to go with definitely Nina Simone as being one of my favorite artists of all time.
Very good choice. What do you got, Erin?
So thanks, John. I think, right now we all need an escape and sometimes TV can provide that. So my husband and I have been watching the show Ghosts. It's about this young couple who inherit an old house. The wife in the couple ends up with an injury where she is able to see ghosts, and there are all sorts of ghosts that live in the house, from different time periods, including a Viking. And it's a 30-minute sitcom and hilarity ensues. So that's been our escape recently.
An injury that allows you to see ghosts. I'm hooked. Okay, guys. So let's first discuss kind of the particulars of what's happening here. And, there's no need for anybody to use a real child's case or anything, but maybe you guys could sort of hypothetically take listeners through how a Maryland youth in foster care comes to end up staying very long term in a hospital stay that was meant to be very short in duration.
Sure. So, I think I can start talking about, how this child may end up in Carrie's care and then hand it over to Carrie to talk a little bit about, how they end up getting stuck in Sheppard Pratt Hospital or not being able to move on. So what we often see is a child will come through an acute care hospital emergency department in Maryland and end up needing some kind of psychiatric care. So what can happen is if the child, needs sort of general psychiatric care, they may be able to get that in one of our acute care facilities, or they may need the specialty care that Sheppard Pratt Hospital system provides. But what we see, and it's not always kids that come in that are already in the foster care system. The emergency department is also the entry point for children and their families to enter into the foster care system. What happens oftentimes is we see kids churning in and out of the emergency department, coming in, frequently. And, quite frankly, their families are not getting the supports that they need to keep them out of the emergency department. And oftentimes families may feel that the only way to get their children the care they need is to enter into a voluntary placement agreement or leave their child in the emergency department. There's this feeling that they are safe there. So what happens after that is the child is stabilized in the emergency department. And then when the proper bed opens up, they are transferred to either the inpatient facility where the emergency department is, or transferred to Sheppard Pratt for their specialty care. I'll let Carrie take it away to talk about what happens to these children then.
Thanks, Erin. So typically what happens is when someone comes in from an emergency room visit, and sometimes it's not an ER visit. We also have our psych urgent care here on our Towson and our Baltimore, Washington campus, which also evaluates youth in sort of a psych ER sort of clinic setting, and they can also be transferred directly up to the units from there. But what typically happens is the patient will come in and the child will get acutely stabilized. So medication changes might be made. There might be some acting out or aggression that occurs. Typically, a stay should be between 5 to 10 days. It really depends, obviously, on individual cases, but that's typically sort of the standard length of stay for some kids. What's really happening now is that, similar to what Erin just spoke to, either the foster parent, or this could be a child that's also already in a group home, needs to return to either that group home or the foster home. They say, you know what, those behaviors, the acting out, the skipping school, all of these types of actions are making it really hard for us to manage this child in our home. They're in a safe place. The hospital can take care of them. And the foster parent essentially says, I don't have the means, I don't have the ability to care for this child, and I can't keep them safe. And what happens then is that clinically, the child may be stabilized. Clinically, the child may no longer need to be in a locked door inpatient facility. However, unlike adults, because I also see the other side of things, unlike adults, where adults can choose where they want to be discharged as long as they're safe, children need to go to a safe place, a home, a group home, a residential treatment center. And depending on the situation, a child can go to any of those three places. What we're finding is that when the local DSS county, and because in Maryland, there are so many counties, we get kids from all over the state of Maryland. We are completely reliant on that specific DSS worker that has been assigned to that child to find a placement. And in Maryland, the DSS individual counties control all aspects of those placements. So for example, we have an RTC here at Sheppard Pratt. Even if we thought maybe that kid would be a good place, that placement would be good for them, we can't directly refer them to that placement. In Maryland, the whole process is done through DSS. So then the social workers and teams on the inpatient units are basically waiting for that specific DSS worker, their supervisor, and trusting, to be honest, that applications have been sent out to whatever level of care that child may need. And some do need, an RTC level of care, residential treatment center. Some need a group home setting. Some are deemed appropriate for treatment foster care. These DSS workers are then responsible for finding a treatment foster care family that is able to care for this child, given, their plethora of trauma history and other issues they may have, or a group home, or an RTC. So that's sort of what ends up happening. And what ends up happening is they get stuck because without that placement, we can't release them anywhere. There is no sort of in-between sort of setting between the inpatient unit and this new placement. There's no in-between area. And so they are essentially, the word that we hate to use, but it's the truth, stuck on an inpatient unit well past their stay.
Okay, so to sum up, it's already kind of a not ideal scenario where the youth has come to you guys and wherever they were before doesn't feel equipped to take them back. And now it's on this worker to go find another option within their array of, capacity within foster care, for the youth who are in the system. And that is where this is coming to a head. They are frequently, not always, but frequently unable to find that next option. And then the youth ends up staying with you guys for a long time. Is that about right?
Yeah, correct. And I think, and sometimes it's sort of said as the youth are coming in the door, we already know from the minute that the kid is coming onto the unit that the foster parent or whomever is responsible for the child is already, saying, I'm unable due to this behavior, even when they stabilize, or I'm not willing to have this child return to my home. So, and then other times it happens sort of midway through their hospitalization, which also means you're starting the process all over again while the child is on the unit. So either can happen.
So, a question, I guess, for either of you on this, on the front end of this experience, when a youth is actually coming to you, you know, do you find that the youth from foster care who come to your front door, either at the emergency department or somewhere else, genuinely do need your help? I mean, obviously, this becomes a stuck, problematic situation later. But do you generally find that you agree with DSS when they arrive with the youth that they need your help, or are they coming to you, frequently with situations where you wonder whether you even needed to be a part of it at all?
I do think genuinely in a hospital emergency department will help everybody that comes through their doors. The crisis system in Maryland is fragmented and broken for every age group, especially for children. So oftentimes emergency departments, or like Carrie talked about, Sheppard Pratt psychiatric urgent care, will see individuals and children who really are in a crisis and need some help. I don't believe that every person that walks through an emergency department in a psychiatric crisis needs to go to an inpatient unit. MHA did a study looking at that, and it was about, a little under 50% actually needed to go to an inpatient unit in all populations. Children are a little bit different. Oftentimes they may need a little bit more to stabilize. And that's why we have services like Sheppard Pratt's and where Carrie works to help that. We don't have enough psychiatric urgent care. So patients do end up in the emergency department when they really could use something else, but that something else doesn't exist in Maryland.
So, Carrie, you mentioned that one part of this that the worker may feel, I'm sure it is, intuitively true, that a youth, when they're with you guys, is safe. Right? There's a very low likelihood that physical harm is going to come to them. But what is it like in terms of just quality of life and an experience for a young person to be, I guess, particularly in the inpatient unit? Because I think probably a lot of listeners have experienced what it's like to be in the emergency room for more than 10 hours. It's horrendous, to even be there that long. So I can't imagine being boarded there. But, for the youth who end up staying for a very long time in an inpatient unit, what's your day like?
Once the kid has sort of been stabilized and is feeling better, there's a couple of things that happen. So, a lot of kids, we can't deny that a lot of kids and especially in the foster care system have experienced trauma upon trauma upon trauma, right? Abandonment issues, having to go to multiple homes. I think, really knowing what happens as far as patient populations, I know what it was like to be a kid. We all do. You're on a unit where you start to connect with the staff. There's probably, unfortunately, for some foster kids, a little bit of an institutionalization thing feeling anyway. But what ends up happening is structure-wise, some kids actually really thrive in the structure of an inpatient unit. So I could say that's sort of a positive that can happen. But other things that occurs, you're watching other kids come and go. You're watching some of your friends that you might have connected with come and go. Schooling wise, it's a big issue, right? So that we have home and hospital in the state of Maryland, but it's very limited. And it's been even more limited since COVID.
What does that, I'm sorry to interrupt, but what does that mean, that they have education provided to them while they're there?
So, right. So because it is an acute stay hospital, there isn't typically education provided because someone's expected to stay a week or two and they get out of school for that time and an excuse is made and they go back to their lives and back to their school. Mm-hmm. We have something called home and hospital in the state of Maryland, which essentially is made for legally to address learning issues for kids who are quote unquote stuck in the hospital for a while. Typically, this would be more of a medical scenario, kids that are at Kennedy Krieger, at University of Maryland, other local hospitals who have more medical issues. And the counties are each responsible for providing a tutoring type of service, but it is limited because, again, this is very specific sort of guidelines, and a tutor, I might not be getting this exactly right as far as hours, but typically it's only a couple of hours a week. And the idea is work is provided. A tutor can come in by the county to sort of supplement while they're in the hospital, but it's all made and designed to be extremely temporary and very limited. So for the most part, these stuck kids, that's not what's happening. And so they're missing out on school. They're missing out on the socialization of school. Some counties are really great with getting some home and hospital in, some are not. And it gets even more complicated if the kid happens to have an IEP, which is even, is not going to be able to be met on an inpatient unit simply due to the nature of an individual education plan. So there's that. There's also limited, we are very lucky here at Sheppard. We have courtyards, we have a playground that's contained within sort of the hospital grounds, that we have a beautiful campus that as long as the kid is on an appropriate behavior and safety level, they can walk around and get outside. It's not like they're on the unit the whole time, but it's limited. It's not the same as being in an environment at home, being able to walk outside whenever you want, playing sports, that sort of thing. We do have a gym here, but again, everything is just sort of on a smaller level than honestly any kid would ever really want. Those are some of the things I can speak to. And every unit is a locked inpatient unit, again, because this is meant to be an acute psychiatric short-term stay. So they cannot come and go at their leisure.
For 2 decades, Fostering Families Today magazine has educated families raising and supporting children and youth in foster care. Delivered in print or online 6 times each year, Fostering Families Today gives families the latest tips, strategies, and research on caring for children with traumatic backgrounds. Use promo code PODCAST5 to save $5 on a print or digital subscription today. Just go to fosteringfamilies today.com/subscribe and enter PODCAST5 to save $5 on your subscription. That's fosteringfamiliestoday.com/subscribe.
Erin, let me ask you, and I'm not sure what kind of data you guys have been able to kind of accumulate for the state. So maybe you guys don't have good numbers on any of these, but I'm just curious, what generally the cost of a youth staying in one of these hospital beds is. And then, what's the age range typically that you're seeing in these overstays? Is it mostly older teens, or is it a much broader range than that?
So, John, unfortunately, I can't speak to the costs. We do know, hospitals receive a very nominal, what's called administrative day rate from the Medicaid program when a child is in the hospital beyond medical necessity for every day. That varies from hospital to hospital. I believe it's in, the $200 to $500 a day range, depending on the hospital, but that does not in any way, cover the actual costs of care that are provided to these kids, even when they are no longer medically needed to be in the hospital. So it can be pretty expensive. The other, cost of this is inpatient psychiatric care for children and youth and adolescents is extremely limited in the state. We just don't have enough beds, enough services. There's just a very limited number of places where kids can go. So what we find is when a child is in an inpatient unit beyond medical necessity, there's probably 2 or 3 children waiting in an emergency room, at least for that one slot, if not more. And I'm sorry, I kind of, as I was talking, forgot the second part of your question.
No, it's okay. And I'm glad you brought that up, because it was kind of like, as I was, doing my research to get ready to talk to you guys, it kind of occurred to me like, wow, this is to some extent a foster care capacity issue that we're talking about, but it seems to be creating a second capacity issue just for the broader mental health system serving adolescents, which, if, we're recording this in late April, the New York Times just came out with a massive story yesterday just about how widespread that is right now. It's not just youth in foster care, or especially them even, who may need these beds and may need some pretty acute help. But the other question I had for you, I'm just curious if we know generally what the age range of the young people who tend to experience these overstays is.
We looked for about 8 weeks in the fall at this issue of youth in an overstay situation. There was a variety. It could be as young. We had, a few babies that kind of fit into the categories that we were following, up to 18. But what we really found is it's really kind of that adolescent period. So, 12 to 17, probably the hardest period in a child's life, to be honest. That's the time period when you're awkward, everything's kind of changing. You're going through just the normal kid stuff. And like you said earlier in the podcast, or maybe it was Carrie who said it, these young people in the foster care system have likely gone through multiple traumas already by the time they turn 13. And then they're in this like heightened state that we all get into when we're that age and kind of coming into our own.
Yeah. It's part of why I wanted to have you guys on to talk about this is that we at the imprint do a survey sort of data collection every year. We ask states, for some basic information about their foster care capacity. How many licensed homes do you have? How many relatives are you working with? Things like that. And then we'll tack on a couple extra questions just, about something specific. So last year we asked, each state, hey, what particular groups demographically, whatever, are you struggling to find suitable placements for? Like where within your system are you experiencing that? And we got 42 states to respond to that. I was surprised, honestly, the 42. Maryland was not one of them. They did provide data on other stuff, but they didn't respond to that one. But 31 of those 42 states said teens and 19 said behavioral health. So I think that this is something that's not going on just in Maryland, though it sounds pretty serious there. We had Les Guerra, who's actually running for governor right now in Alaska, who's a former foster youth, say similar things going on in Alaska. They're seeing youth just getting stuck at the hospital. Carrie, what's like the extreme end of this and what's average? I mean, how long is a youth who experiences an overstay typically with you guys? And like, what's the craziest amount of time that you've personally experienced at Spencer Trapp?
So I've been doing this a long time. And thankfully, I think with Erin's people, I think probably months, a significant amount of months is the longest. And honestly, I mean, I'm not trying to be vague here, but really a day after you're expected to be discharged is too long for me, but there's months, I mean, and I think it got worse. I will say, I do think, just to speak on that, COVID just made it exponentially worse with the staffing issues that clearly, to your point, every state is experiencing that we already have. So even if there was a placement, there would be times where the group home or the message would come to us to the district, through the DSS worker that would say, this place wants them, but they can't take him for 3 more weeks because they don't have the staff to adequately house him or her. And so the discharge date could be pushed off for weeks simply because they didn't have enough staff. And that happened a lot over COVID. And then there was other people say, we really want this kid, we want to take them. But again, this is another reason why we don't have enough staff on the weekends, or where in the past with things like this, if something like this came up pre-COVID, it would be a day or two. Maybe there was a staff that wasn't scheduled properly. We're so sorry, but instead of Thursday, can we push this discharge till Saturday? And that way we have the appropriate staff, but nothing like this. But I would say, some months, and it's only sort of increased with COVID.
Erin, I suspect that you have been in dialogue, you or at least the association, with Maryland's child welfare leadership on this over the years. I mean, what do they have to say about this? Do they acknowledge this is a problem on their end, or what's their general viewpoint been on this issue?
I will say this: they do acknowledge that it's a problem. They have been, at least of late, trying to coordinate better with other agencies. So when we talk about the child welfare system, we tend to go to a DSS. In Maryland, it's called DHS, Department of Human Services, and think, just about them. But when we're talking about these kids, there's usually multiple state agencies and local agencies that are tasked with coordinating some aspect of this child's care. So it could be, not just the local Department of Social Services, but their school system. Maybe this child has a developmental disability. So to the Department of Health, maybe at some point, they were touched by the juvenile justice system. So they can have multiple state entities that need to be coordinated. And I think that this is really one of the hardest aspects of getting that coordination. And some of what happens is just administratively, there's no quarterback for this kid's care. And when they're in the hospital, it could be a social worker or someone, if they're in Sheppard Pratt, someone on Carrie's team that is quarterbacking their care. But then when they leave, there's no state entity that is really taking control of the care for this kid and their family. So whether it's their foster family, their group home placement, a kin, a relative, there's no support that is readily offered for their families.
Yeah, to that point, Carrie, I was curious for your perspective on this. I mean, again, I hate asking you to kind of average out the experience of youth because I know they're individual and unique every time, I'm sure. But for the young people that you clear as not medically needing a hospital anymore, do you feel like the majority with the right kind of supports, could go home to a relative caregiver or to just a regular foster home? Or would you say that the majority of them, while they may not need a hospital anymore, need a higher level of, therapeutic environment than that?
Yeah, I think, again, and to your point, yes, it's hard to sort of average or summarize, but knowing what I do know, and in the past, especially in the past couple of years, I think that the patients and the kids with the longest length of stays related to this sort of thing is really in regards to their histories and the types of behaviors that kind of brought them into the hospital in the first place, and how complicated the nature of their illness might be. And I think it's never necessarily sort of this, if you magically had this like wonderful group home that was willing to take complicated kids, if only we had 5 of them. These kids have long, complicated histories. And sometimes is it looking past that and giving them a chance? Absolutely. But these different levels of care, I think, is a big one. Because I think, and it's also hard to say, because when they come to us, by the time they come to an ER or to an inpatient unit, there's so much of a history there. I mean, honestly, John, it's hard to say how this particular kid ended up where they are, because oftentimes, to Erin's point, many systems have failed them so many times along the way. It's so hard to sort of pinpoint, if there was this, amazing wraparound service a few years ago, could this kid have been segued this way? And our systems, to Erin's point, we have a lot of, it's like all these different entities, all these different systems within Maryland, all individually seem to be doing really great with trying to make strides towards solving this problem, but there's nothing sort of joining them all together. So one sort of specific example I can give is that DJS, or Juvenile Services Department, has really sort of tried to champion this idea of sexual offenders and kids that have perpetrated on, and for many reasons, obviously, this is a young person that's very difficult to sort of place in an environment regardless. But you have to be involved with that agency in order to receive any of those services. So if there happens to be a particular patient who maybe has issues related to that, but no one has ever pressed charges and nothing has ever happened, there isn't anything for that kid, right? So you have to be a part of every system individually to sort of get those services. And it's challenging. It's really challenging because they don't necessarily always talk to each other. But I think preventative services is probably, to Erin's point, the thing that we need more of, to be honest. But yeah, no, I don't necessarily think that, if all the staffing issues got resolved in all these group homes with COVID and everything else, that some of our stuck kids would be as easy to find support for.
Yeah, that's a fair point. I mean, even if you did feel, okay, theoretically, this young person could go home with grandma, if we are surrounded, the services, that also assumes grandma feels okay to do it and equipped to do it personally, which has nothing to do with clinical services. It's just human beings and what they're capable of or feel they're capable of.
Are you a professional in the field of child welfare, juvenile justice, or other family and youth services? Subscribe today to Youth Services Insider, the imprint's exclusive section on all the insider news you need to stay in the know. Funding opportunities, major federal and state policy shifts, interviews with key leaders in the field. It's all available only for our Youth Services Insider subscribers. Sign up for a monthly or yearly subscription today by visiting imprintnews.org/subscribe. Our podcast listeners get 10% off their subscription by entering the promo code PODCAST10. That's imprintnews.org/subscribe and get 10% off your subscription by entering the promo code PODCAST10 today.
Okay, so outside of, case management, let's talk about kind of policy solution. The issue here is child welfare agencies placing some kids into hospitals and then they end up staying there too long. There was a bill introduced, I believe, this session to try and address this. So, explain, one of you, to listeners kind of what that bill would do specifically, without getting into too much legalese, to stop this from happening. Like, what is the proposed legislative solution that's recently been on the table here?
Well, thanks, John. And I think this is a little bit of my sweet spot, trying to discuss legislation without getting too legalese. But I'm going to give you just a little bit of history, if that's okay, on this legislation, because it was introduced this year, House Bill 406 by Delegate Krill Resnick of District 39 in Montgomery County. We're very thankful that he did introduce the bill this year, but he's been on this for a long time. So there was legislation back in the 2020 legislative session. Maryland's legislature is part-time. They meet for 90 days a year from January through April. 2020, as we all know, was a very interesting year. So Delegate Resnick and Delegate Learman, at the beginning of that session, when everything was going well and we thought 2020 was going to be our year, introduced a piece of legislation to address this issue. Then March 2020 happened. So there was a lot of work happening. MHA, the Hospital Association, and other advocates were involved, in all of this work. And then everything kind of fell apart. Maryland's legislative session adjourned after 70 days. This was the first time since the Civil War that they did not have a 90-day session. And unfortunately, that bill at the time, was left behind, as a lot of things were. This session, Delegate Resnick decided to resurrect that piece of legislation with all of the changes that it had already gone through during the 2020 session. He was able to get the bill through the House of Delegates, and it moved over to the Maryland Senate in a really good position. MHA was very, very interested in it for a couple of things. But the number one thing we really liked about the legislation was that it created this coordinator entity at the state level that would have to work with the various agencies and be the point of contact, not just for hospitals to get the care, to know where this kid needed to go, but for the other agencies to start talking to each other and kind of break down some of those silos. So that was really, really important to us. And it also set up a work group that would look at longer term solutions. It dedicated some funding to develop some new placement options. And it required that every time a child in care entered an emergency department or a hospital, that the Office of the Public Defender was notified, because these kids, do have a right to counsel like everybody else. So for us, we were very excited about this piece of legislation, and we were really hopeful that it would get through. But unfortunately, given that our session is only 90 days and it adjourns when it adjourns and then it's over, we didn't quite make it over the finish line, but we did get further than we did in 2020.
So do you feel it was a time issue as opposed to support? Like, if this was twice as long a legislative session, they might have gotten to it and passed it?
Yeah, for sure. For sure it was. And back to something that was said earlier about the idea that kids are safe in a hospital. The senators in JPR did not want to push something through at the end of session that would make things worse for these kids. And so they really wanted more time to think through the issue, because in their minds, these kids were safe in the hospital. And that is, they're physically, they may be safe, but is the hospital the best place for them to be? Absolutely not.
Yeah, it's tough to hear that, because that is just it's the mentality that creates a lot of problems in child welfare, not just in hospitalization. But I guess to their point, I read I think it was the local chapter of the National Association of Social Workers seemed to have concerns about this bill that seemed to, if I was reading it right, be around like, look, you can put people in charge or whatever, but if we don't have more resources and money to create the options you want these youth to go to, we're going to end up with these kids in hotels, and that might not be safe. That seemed to be kind of their thrust. I mean, by the way, I don't know that that's necessarily a criticism of the bill, because even if it created that problem, you're one step towards proving, okay, we need to do more. But are they right? I mean, do you feel like even with a good coordinator in there would still be something missing in terms of the investment in stepping kids down correctly?
I don't think any one piece of legislation is going to solve all these problems. I
Right.
think there's going to need to be significant investment in the child welfare system, significant investment in breaking down those silos, like Carrie said earlier about that program that's available through DJS, but not available to a child who hasn't already been scooped up in the DJS system. Why do we want to wait? Why do we want to only make something available after you've already gotten into a bit of trouble? I think that to an extent, we're all looking for a silver bullet, and there's not going to be just one. We're going to have to work on this for multiple years, which is, why we at MHA were happy to see a kind of longer term policy group to come together that could talk about all of these things.
The coordinator piece of that Erin speaks to, it seems like, when there's such a sort of unnerving problem like this, and it is sort of disturbing to people, you just, want to get at it right away from any different angle. But really, you're talking about so many just different bureaucratic entities working together. And I will say what I saw work really beautifully was MHA, got together a bunch of hospitals in the Maryland area to make sure, I think it was Erin went over like 40 hospitals to make sure they were getting accurate information, that they were pulling data about, demographics on these kids and the reasons why. But because it was a coordinated effort, we all ended up talking to each other and sharing stories and figuring out, well, my problem's different in the ER, and it looks really different on a psych inpatient unit than it does at University of Maryland, ER or Children's or somewhere. So I just think just the place to start for this coordinator idea of like the proverbial, I don't want to say like the herding of cats of government entities, but there has to be someone just sort of that their sole position is to start chipping away at DJS's way of dealing with these situations, DSS's, and there really isn't one person to sort of point fingers at. But I will say, this wraparound, in my opinion, yes, the services, to your point of what the social workers were mentioning about, that's good and well, but until we have what we need, it's hard to provide. Investing more in these services before the kids get to us, which I think everyone's been kind of pounding that drum for a long time. And I also think it's easier said than done. But I think if you have someone, though, whose job is to start creating that based on all this information, I think it's a good place to start.
Yeah, and probably that coordinator, that position would be, the effectiveness of it would be contingent maybe on that person having the ability to cut through some of the stuff that you were describing, Carrie. Like, okay, we know this youth has had sexually aggressive behavior, even though they haven't been arrested for it. I'm going to unlock this service without him needing to be arrested or something,
And understanding the nuances. There's so many. I mean, Erin was kind of laughing at like trying to be able to sort of unlegalize some of her speak so that the common of us can understand it. Yeah. But she's right though. And so there's so many of us that there's policies and there's agency rules, and it's so hard to navigate even as a professional, that again, yes, to have that person to be like, yes, they don't fit in this box, but I can call so-and-so at this agency and help you understand it.
And that's so important. I mean, that's something that we've heard, not just from Carrie at Sheppard Pratt, but from all of our hospitals and hospital staff, is that there doesn't seem to be anybody or any entity that can break down some of the barriers. So when the state, does move forward with some of the solutions on this problem, the people need to be empowered. I think, we've also heard about, from our social workers that sometimes, even the child's DSS caseworker knows, what types of barriers they're bumping up against, but is not empowered to remove those barriers. And that can be frustrating, not just for our hospitals, but for that DSS caseworker as well.
Sure. So Erin, you seem hopeful that given another bite at the apple next year, you might get legislation through. Now, the other way to try and kind of compel change is through lawsuits, which happens all the time in child welfare, and I would suspect in medical care and hospitals. I think there's a kind of long running situation with this in Baltimore, but I mean, I guess specifically to your constituency, right? The hospitals. Have you guys considered litigation, or is that something you may do if you can't get a bill by next year passed?
So, John, that's a great question. And I have heard the rumors about, some of the lawsuits that may be filed on behalf of Baltimore City foster youth or statewide. That's not really in MHA's wheelhouse to do something like that. We are an advocacy organization, and we will continue to advocate for changes to the law to benefit these children, and the suggestions that we get from people like Carrie. And I'm so glad you have her on here with me today. I should have said this earlier. I absolutely adore working with Carrie and learning from her. So we will continue to think about ideas for policy change, run them by our members, including Carrie, or get them from people like Carrie, and try to use our legislative champions to change policy at that level. But we do not file lawsuits on behalf of our members.
Erin Dorrien of the Maryland Hospital Association, Carrie Etheridge of Sheppard Pratt. Thank you guys so much for joining us on the Imprint Weekly Podcast.
Thanks so much, John.
Thanks again to Erin Dorrien and Carrie Etheridge for joining us for this interview. The Imprint Weekly Podcast is a production of the Safe Camp Audio Network, which is a division of Fostering Media Connections. Please visit safecampaudio.org on the web or at safecampaudio on all major social media. This podcast is produced and mixed by Christine Anjoko with music by Luke Giroux and Cyrus Elia. If you enjoyed this episode, we would love it if you would consider subscribing or giving us a 5-star rating on Apple, Spotify, or wherever you download your podcasts. And we would greatly appreciate if you would consider supporting our work here on the podcast and in print. Small donations from our listeners and readers go a long way towards helping us grow and cover more great stories in child welfare and youth justice. To support us, it is super easy. Just visit imprintnews.org/donate. You can follow The Imprint on Twitter and Facebook by searching the handle @TheImprintNews and visit us on the web at imprintnews.org. You can always get us over email at tips@imprintnews.org. I'm John Kelly, and we'll see you next week.